Good morning, everyone. On behalf of Mending Kids, I'm delighted to have our panelists present a virtual educational symposium on pediatric sinus disorders and management. Mending Kids is a nonprofit that provides critical surgical care to children all over the world. And our panelists today either work in Tanzania or have led missions to Tanzania. And this event is meant to provide an exchange of knowledge for everyone. Our moderator today will be Dr. Lia Jacobson, and she will be introducing the panelists. And I'd also like to remind everyone that questions will be held until the end of the symposium, at which point you can, in the Q&A section of your Zoom screen or your webinar screen, pose your questions, and they'll be moderated, and then they'll be addressed and discussed. So without further ado, I'd like to introduce you to Dr. Lia Jacobson.
Hi, everybody. I'm Lia Jacobson. I'm a pediatric ENT surgeon at UC San Francisco in California. It's my great honor to represent our panel today. Our topic will be on the management of pediatric sinus disorders. And we have some great speakers. As Isabel mentioned, all three, and including myself, 4 of us have ties to Tanzania, and one of our speakers is a local otolaryngologist at the Kilimanjaro Christian Medical Center, Dr. Denis Katundu. We'll kick off the day with one of my colleagues, Dr. Ayal Willner, who has spent time with me at the Bugando Medical Center in Mwanza, Tanzania. And our final speaker will be one of my esteemed colleagues here at UC San Francisco, Dr. Andrew Goldberg. He's the director of rhinology and sinus surgery at UC San Francisco. So I'll give another brief introduction to all the speakers, but I will first turn it over to Dr. Ayal Willner. He's, as I mentioned, a pediatric ENT and a Mending Kids board member. He works in Southern California with the Southern California Ear, Nose, and Throat surgery group in Long Beach, and him and I have been to Mwanza a number of times. I believe he's been about 3 times, and we'll be going back in a week. So he'll be speaking on pediatric sinus anatomy and safe endoscopic sinus surgery approaches. So without further ado, I turn it over to Dr. Willner.
Ayal, you're on mute.
How about now? Can everybody hear me?
Great.
Yes.
All right. So thank you again. Thank you very much. It's great to be able to give this little talk on pediatric sinus anatomy and prevention of complications in pediatric functional endoscopic sinus surgery, or endoscopic sinus surgery, depending on when you actually learned about this. Mine was a long time ago. The pediatric, doing sinus surgery in kids was firstly largely reported in the United States in about 1989, a group of 586 children by Dr. Randy Lazar. And a lot of things have happened over time. So the first, hold on, trying to bring my screen. Nice, go on, hold on. There we are. Pediatric sinus anatomy. The anatomy changes with time. We're born with present at birth are maxillary and ethmoid sinuses. But the frontals and the sphenoids are not yet there. These lines right here are at about 4 years of age, 8 to 12 years of age, and this is kind of the adult size. It's important to know that because when it doesn't reach this on time, there are things to look for from a surgical point of view to keep the anatomy safe. The other thing that is important is that the sphenoid does not develop. Here's the sphenoid developing over time. This is when you may first see the maxillary of the ethmoid when they start developing, and when you see them radiologically, and the frontal and the sphenoids when they first start to be seen. These are approximate times. Sometimes the sphenoids are ahead of the frontals. Sometimes the frontals are very large, but it's just something to consider. There are differences in sinus development. I mean, the whole idea of pediatric sinus anatomy, pediatric runs as is obvious from the 0 until adults. And so when we look at a CAT scan, when we plan our surgery, we need to keep that in mind to make sure that our distances change over time, the size of the sinuses change over time, and so those things all need to be kept in mind, as well as things like concha bullosa and other anatomic variants which develop over time. Septal deviation of a septum, which may make one side more difficult than the other, more likely in an older child than in a 1-year-old. The other thing another implication is that certain surgical instruments may not be able to be used. You might need to use something smaller, something different. This is all just something to keep in mind. Then as well, the risk of complications is a little bit different. Older kids and adults are more likely to have a CSF leak, and children or younger kids are more likely to have orbital injury. Probably the CSF leak is you're not going to be going towards the frontal sinuses often. You're not going to be going to the sphenoid. So you have those kinds of anatomic things that you need to think about, and that's probably why the orbits are more likely injured in younger kids, because we're not going towards the sphenoid, we're not going towards the frontal in those younger kids. So in general, in terms of safety when performing sinus surgery, involves the first thing is appropriate learning and appropriate training. Reading about it isn't enough. Doing an observership probably isn't enough. Doing a course is something that is probably should be considered strongly, depending on how much training one gets or one received in their residency. The main thing is to remember how much training you had and how comfortable you are, and not to push the envelope too quickly, because pushing the envelope in this case can lead to the orbit and the brain. And of course, if there are options for image guidance and telemedicine consultation, that should be something that should be set up beforehand. To call a colleague and say, if you have the ability to put, let's say, the output of a telescope video onto a Zoom call such as this, calling a colleague who may have more experience to say, hey, can you watch this case while I'm doing it? And hopefully they will say yes. But in the end, it's your practice. These are your patients, and it's up to you. In terms of preoperative steps to avoid complications and have safe surgery, one of the main things is evaluating the CT scan for anatomic variations. Things like dehiscences, we'll go into those in a moment, but looking for the anatomic variations, post-traumatic variations, things that can get you in trouble, as well as planning your surgical approach. It says here small hole versus large hole. You don't necessarily need to take out and open up every single sinus cavity to affect an improvement in the patient's condition. Sometimes opening up the bulla and maybe some of the anterior ethmoid may be sufficient. It depends partially on when you look at the CT scan, where's the disease? Now that does not correlate 100% in terms of what you see on a CT scan, what you find on when you get in. In fact, there's studies that show a large variation. However, take your level of comfort and use that as your planning guide to say, how much are we going to actually open up? And then intraoperatively, it's all about visualization. Studies have looked at complications, and when visualization is down, complications go up. So the first thing is hemostasis. The second thing is your telescopes. And the third thing is making sure that you're not going too far into an area where you can't see, so you don't get led down into an area that is dangerous. And there's a learning curve. Stankiewicz in 1987, for his first 150 procedures and 90 patients, had a 29% complication rate, which included CSF leak, temporary blindness, major hemorrhage, orbital hematoma. But the next 90 patients was down to 2.2%. And now, in a more recent look at 2003 to 2007 by Ramakrishnan, their major complication rate was down to 1%. So with training, with practice, with the new aids, new techniques that we have, and new instrumentation, when Stankiewicz was doing this in 1987, we did not have through biters. We only had Weil's forceps that were basically pulling and tearing. And so we have a lot of things that have changed that allow us to do this a lot more safely. So safe surgery, things to keep in mind that in general, the skull base slopes downward at about a 15-degree angle. So things that look very high in the front of your sinuses as you're putting your scope in are going to come lower. Again, looking at the CAT scan will allow you to look at the skull base in the sagittal view. Also, as we go further into the nose, the sinus cavities widen so that you have more room to go laterally and be able to reach sinus disease. If we stay just infromedially, which is where we usually want to start our dissection, we will miss some of the disease that is there a little bit more laterally. Again, it's knowing the anatomy, knowing that it widens, knowing that it slopes downward, which will help us go from where we enter things generally, which would be infromedially, that's generally the safest spot, to the further reaches of the sinuses. So some of these are subtle, some of these are not. When you're evaluating the CT scan, things you want to look for are things like the lamina papyritia not being intact. It can be due to tumor, it can be due to fungal ball, it can be due to trauma, it can be little, as we see on the left here with the left lamina papyritia has a little bulge, or it can be a lot more obvious, as you can see on the right side. The anterior ethmoid arteries are things that are relatively easily injured as you're operating up near the skull base. Sometimes they are not so obvious, and they're not up against the skull base. Here is an anterior ethmoid artery right here, and on this CT scan, you can see that it is not up against the skull base. It is kind of hanging down. But one of the key things you can look for is this beak. This beak will take you to the anterior ethmoid artery. It's kind of towards the back of the globe, and it usually will be behind it'll be behind either the frontal recess or supraorbital ethmoid. Once you start approaching that area, it's something that you definitely need to evaluate. Skull base dehiscence. It can be small, it can be medium, or it can be really large. So But again, these are things that are evaluable. You can evaluate it preoperatively and then stay, first of all, plan your surgery and say, well, wait, this patient doesn't need sinus surgery. This patient needs skull-based surgery. This patient needs an MRI to see if this is an encephalocele, to see if this is a meningocele, and this patient may well need a neurosurgical consultation pre-op. And so these things need to be evaluated, and they need to be evaluated not right when you're about to start surgery, but much earlier. This is one that is relatively common, and that is a hypoplastic maxillary sinus. On this side, this patient is 12 years or older, most likely. And on this side, it's up at the 4-year-old level, about halfway up the internal wall here. The main thing, and it's a little bit hard to see, but the uncinate plate curves around like this. And what you'll find with these atelectatic or hypoplastic sinuses, the uncinate plate is lateralized and is up against the orbital floor. These are the situations where it's very easy to try and either, if you're trying to take your uncinate plate off with a sickle knife or with a side biting punch, you can end up going into the orbit. And then when you're trying to go in with your suction into this area, obviously it's very easy to get into the orbit. So these things are very important to note. In fact, all these anatomic variations, there's nothing wrong with them. They're not terrible. It's not something you can't do. It's something you have to note and take into account. Once you do that, then your surgery will be a lot safer. And then the other thing is the Phobia Ethmoidalis. It can be shallow, it can be medium, it can be long. This is where the olfactory nerve sits right above the cribriform plate. You can have it different levels. And so if you're going in on this side and you see, oh, I've got this nice high fovea, you have to make sure that you have the same thing on the other side. Otherwise, you can definitely get into the intracranial space, which is not what we're trying to do. The sphenoid sinus, getting the sphenoid sinus, you can have a couple of things going on. The internal carotid artery can be dehiscent, and it's very easy to come in at a little bit of an angle through the sphenoid ostium and go towards the side and hit the carotid artery. And I won't go into treatment of carotid artery complications and try to control that bleeding in this talk, but it's something that you definitely want to avoid. Very high risk of morbidity and mortality with an internal carotid artery injury. Sometimes it's not so easy to see, especially when there's a lot of disease all throughout that you're just trying to get through. Over here, we can see a right onodi cell. That's a posterior ethmoid cell that's going above the sphenoid sinus itself. It's characteristic for having an optic nerve that's not covered, that's dehiscent, not covered by any bone, leaving a fair amount of risk to that. And again, that doesn't mean you can't operate there. It doesn't mean you shouldn't operate there. It means that you need to evaluate the CT scan and know where you're going. And that's true in any of our surgeries, that when we know what's potential pitfall, it's a lot easier to avoid it. So the next thing is hemostasis. I'm not sure what everybody's using. When I first started training a very long time ago, we were using halothane. And generally, when you're using lidocaine with epinephrine and halothane, we were using about 3.5, the limit was 3.5 mg per kg of epinephrine. And we generally think about how much lidocaine we can give. But if anybody is using halothane, then you really need to worry more about the epinephrine than you do about the amount of lidocaine. So I'm not sure what everybody is using, but halothane and enflurane, the main thing is to look at how much epinephrine you can use in order to get a significant vasoconstriction to allow for a lot less bleeding in your field. And then topical use of epinephrine, I use either a 1 to 5,000 or 1 to 10,000 dilution. I color it with marker ink or fluorescein or something so that that will not be injected into the patient. Very important to mark all the syringes and make sure that you know what you are injecting. Oxymetazoline and neosynephrine are also great, give you a little bit longer term decongestion. The oxymetazoline, less cardiac effects of tachycardia. In general, when you're using the lidocaine with epinephrine, the injection, you want to see if what you injected had an effect on the heart rate. And if it did, you may want to hold off on using the topical epinephrine. Some people use cocaine. I personally don't use cocaine in kids. Cocaine can potentiate the effects of epinephrine. So all these things, we want to keep the blood pressure normal. We want to keep the heart rate relatively normal. The good thing about epinephrine is it doesn't last. The cardiac effects, the hypertension and tachycardia will generally resolve after a relatively short period of time. Hemostasis. There are lots of ways to stop bleeding. There is packing with your epinephrine. I use my epinephrine packs or oxymetazoline packs. And give it a little bit of time to work. Don't just put it in and pull it out, because it'll continue to bleed, continue to obscure your view, and continue to increase risk of complication. You can use a suction bovie, a suction monopolar. That's fine for if you're not really at the back in the sphenoid recess, you're already kind of close to the optic nerve. You can go kind of within about 1 centimeter or so of the skull base. Otherwise, I usually try to switch to bipolar cautery. But down low, you can use monopolar, and I would use it on a low setting, not on a very high setting. And then other hemostatic agents are Surgicel or gel foam with thrombin on it. You put a little bit of gel foam with some thrombin. You put a pack on top of that, and you hold it in position with a little bit of pressure, and then that will often either resolve the bleeding or decrease enough that you can take care of it by cautery or some other method. Flow seal is not always available to everyone, but it is a great hemostatic agent. And then, of course, worst comes to worst, you can pack the nose, unless it's something like the anterior ethmoid artery, in which case you need to make sure that it's not bleeding into the orbit. But if it's just venous packing due to chronic inflammation and bad disease, you can always pack off the nose, and you can stop the surgery for that day and come back on another day. That's okay. Equipment. So the telescopes is 0 or 30 or 45 degree, depending on what your institution has, and a 70-degree scope. 70 degree I use not that often when I really need to look around a corner, but mostly the 0, and I use a 30-degree telescope. Those are probably the minimum you need to do safe sinus surgery. The instrumentation on the left here, there is our prep tray. It also has a freer on it. It has a suction, Fraser suction. And that's all for prepping. You see on the right there, the little yellow, that's the fluorescein. So I know that that's my epinephrine 1 to 5,000 or 1 to 10,000. And these are our sinus instruments. I have a whole big tray of sinus instruments. This is about what I use 90% of the time. You don't need a whole lot to do it. This one right here is a very small backbiter. Biters to the left and the right. And again, you can always flip it over. If you only have one, you can flip it over and use it to the other side. Probes so that you can carefully and gently move things around, and instruments that will bite and cut through are usually better than instruments that will just grab and tear. Although if you're trying to just pull on a polyp, then you can use the Weil's forceps and effectively do what you need to do. So it's a combination of moving instruments, probing instruments, and biting instruments to get you to be able to visualize what you need to visualize and then take out what you need to take out. And of course, the telescopes. You need a good light source because poor lighting is dangerous. You can improve your view by turning down the room light. But again, poor lighting is dangerous because visualization is not good. And when you have bad visualization, you have increased risk of complication. Camera with a monitor. Way back when I started, the training was a split beam camera that attached to the telescope, and I would look through the telescope and my preceptor would be looking on the monitor. Nowadays, pretty much everything is done just by the monitor. But the good news about that is it's a good way to train, and B, it's a good way to get a consult. As I said earlier, trying to, if there's a difficult case, find someone that you can Zoom your output from your monitor with them, and then or whatever it is, WhatsApp, whatever, and then have them guide you. Now, image guidance is great if you have it. Not every place has it, but it basically creates an algorithm from a CT scan, and in the end allows you to put an instrument into the nose, and it shows up in the axial, coronal, and sagittal planes. It tells you where the tip of that instrument is. It's a nice little angel on your shoulder that says, "Hey, you think you're there? I think you're there. Great. Go ahead." Or it might say, "You think you're there? I think you might be someplace else. So perhaps you want to reconsider." And in those situations, you always have to be the right one and not the image guidance. But it's when you use that image guidance to help you say, "Okay, now I better understand the anatomy. Now I know where I'm going and I know where I am." And that's how you're going to stay safe, by using it that way. To sum up, you need to understand the anatomic considerations. There are age-related anatomic changes, post-surgical anatomic changes, post-trauma, post-tumor, post-whatever. There can be whatever, and you have to therefore review the CT scan to find those areas where you might get in trouble before you actually intraoperatively find those areas where you might get in trouble. Hemostasis is related to visualization, and everything is really related to visualization. And the equipment that you use, you don't necessarily need a huge set to do safe, reasonable sinus surgery, but there are certain things ahead. So, and again, plan ahead, evaluate the scan, have a reasonable plan. Do what you need to do. Do what you're comfortable doing, and if necessary, you may want to, especially with bad polyps and bad sinus disease, do most of it, then pack the nose, let everything stop, and then come back and do the rest and do the rest of what you need to do. And of course, the telemed consultations, now that we have the ability to do that, are truly amazing. Thank you. And I'm pretty close on time.
Thank you, Ayal. Wonderful, wonderful start to our presentation. I just wanted to remind all participants, we have a Q&A box. If you have any questions, we'll save them to the end, and I'll help sort of lead a panel to discuss some questions as they come up. So feel free to type in your questions. I also had asked everybody to include if they're willing to share the country that they're from, and I just wanted to highlight what an incredible honor it is to bring such a group of ENTs and healthcare workers together. We have participants from Tanzania, Zimbabwe, Uganda, Nigeria, and Democratic Republic of Congo. If I'm missing anybody, please include it in the chat, and I will highlight you in between presentations. But without further ado, I'd like to move on to our second speaker. Dr. Denis Katundu is an otolaryngologist at Kilimanjaro Christian Medical Center in Tanzania. He's also in the process of completing his PhD in the Netherlands and focusing on pediatric ENT topics. So it's my great honor to introduce Dr. Denis, and he will be doing a case study on chronic sinusitis and antral choanal polyps, a case that they performed at KCMC.
Thank you very much, Lia. It's my honor to be part of this team, especially this time. As been introduced, I'm Denis Katundu from Tanzania, in the northern part of the country. I have nothing to compete. So briefly, I'm from Kilimanjaro Christian Medical Center. This is the zonal consultant hospital in the northern part of the country. We just turned 50 years of services, and we serve about 4 regions around us and about a population of 16 million population. It's the only well-established ENT department in the hospital. So it's called the name Kilimanjaro comes after the mountain, which you can just see in the background of the hospital. And this is the aerial photography. I'm just presenting from this building. And this is the entrance of our beautiful hospital. So I'm presenting a case of a 7-year-old male who came for our attention from about 187 kilometers away from the hospital. He was referred to us due to failure in his medical therapy. And the chief complaint on presentation was nasal congestion for 4 years, which was associated with nasal discharge, mouth breathing, and recurrent fever alongside headache and obstructive sleep apnea. So when we received him, back in his history, he was just born normally, and then during delivery, the mother was informed about the partial abnormality. He is the firstborn. The secondborn is 3 years old, and he was quite fine. So he has been on several medical follow-up by generalists in the peripheral hospitals with oral antibiotics, intranasal steroid, and decongestants without satisfactory outcome. So first, when he arrived to us, he was a fully oriented child. He was snoring at rest with his lips dried because of dehydration from small breathing from the mouth. He was having an obvious cranial synostosis with a short neck. He was malnourished with his umbilical hernia, which was not obstructed. He had blue cornea to highlight. So performing our ENT examination and head evaluation. So he had bilateral multicellular diffusion on both sides. Looking on the nose, he had an obvious pterocontus, you can see it, with a mucopurulent discharge from both sides, but it was more from the right side. He had a non-pulsating polypoid mass from the right nasal cavity. So looking on the neck, on the oropharynx and the neck, he had an high-pitched palate. He had macroglossia with grade 3 palatine tonsil, short neck, and he had non-pathological level 2 nodes. We could not perform fiber optic nasal endoscopy because of his comfort. So we woke him up. We performed an audiometry which showed a moderate conductive hearing loss, and then we could not perform the tympanometry because of the logistic issues. But performing the chest X-ray showed infiltrated with cardiomegaly, and the echo highlighted for pulmonary hypertension and features of right-sided heart failure. And then we ordered an abdominal ultrasound, which showed an obstructed umbilical hernia. The CBC was normal with a raised ESR of 22 millimeter per hour. So we counseled the parent for exgenome sequencing, which we got the results from our colleagues in Netherlands, and it was normal. So the CT scan ordered, and then you can obviously see opacification of masses on the both nasal cavity and nasopharynx. And again, the maxillary sinuses were fully packed with these lesions. Looking on the ethmoids were all opacified. The concern has been presented by the previous presenter. Looking on the skull base, there was feature convincing of the dehiscence anterior plate. So we gave a concern for multidisciplinary approach. We invited our colleagues on board, and then our differential, our diagnosis ranged from a sinonasal tumor, chronic renal sinusitis, we didn't know what syndrome could be until we've shared with our other colleagues, and an obstructed umbilical hernia. So we made the family aware of the involved pathology and the planned surgical management, and we approached on board our colleagues because of the anticipated challenges. We informed either the anesthesiologist, ophthalmologist, general surgeon, and we scheduled for bilateral. We scheduled this patient for bilateral fractionoscopic sinus surgery plus biopsy and bilateral laryngotomy. And then we anticipated, of course, difficulty securing the airway, which was the case. And then we had to perform a tracheostomy beforehand. We intraoperatively we extracted a massive polypoid lesion from the right middle meatus and maxillary ostium. We extracted a huge intracoronal polyp from the same right side. Sphenoid ethmoidectomy was done, and polypoid air cells and polypoid tissues were identified. We had to do adenoidectomy because of the situation intraoperative with huge adenoid obstructing about 100% of the posterior nasopharyngeal space. So these are the intraoperative videos, which I will just show for the interesting part. So you can see there's nothing because we had already performed the tracheostomy, and this was the lesion which was visible preoperative. So we decongested with epinephrine lidocaine mixture. So we packed with adrenaline lidocaine cottonoid for decongestion, and we had to address the disease. So luckily, we managed to exenterate the whole disease. We didn't find any trouble intraoperative with the skull base. And we presented this lesion separately because we found lesion on the middle cabinet on the right side, which are polypoid. We find another polypoid tissues on the maxillary sinus, sphenoid sinus, and ethmoid sinus. And then we had to look to send again lesion from the adenoid side. So we managed to perform the surgery, and then in hand with that, we had to do a microdebrider assisted inferior submucosal tapinoplasty because of how the situation was in the nose. We irrigated lubricated the nose sufficiently, and we packed the nose with Vaseline gauze, which stayed for 48 hours. We continued the patient with dexamethasone. We prescribed anti-pain, paracetamol, and ibuprofen. Tramadol and pethidine was given. And then immediately post-operative, the child had oxygen dependence for 48 hours, which was explained even beforehand. And then post-operative, after pack removal for 48 hours, we did a serial-nasal declassing. So we sent these tissues for histopathological opinion, as I say, 3 tissues separately. So the first lesion was from the middle tabinet. This is the polypoid attached to the middle tabinet. Second lesion was from both maxillary sinus and the antral polyp presented, and the third lesion was from the adenoid, from the posterior nasopharyngeal wall. So the results all came to be polypoid tissue with just a reactive follicular hyperplasia, no any malignancy identified from the STANDY study. So just to highlight, chronic renal sinusitis in children, we expect it to be fully diagnosed based on the clinical grounds. And then in selected patients, especially those who are planned for surgical management, a paranasal CT scan is obtained. I have to highlight this because of the resource that we have, particularly in this part of the world. And then the clinical diagnosis based on the duration of the illness and complex signs and symptoms, this can be contributing to late presentation to our places. So looking on what our friends have seen, we are also seeing the same thing with the local contributing factors, especially the nasal septal deviation. We're thinking probably due to the same existing reason like traumas, increasing NICU care with nasal instrumentation such as NG feeding tubes. And information are almost the same that we have seen upper respiratory tract infection being majority with viruses, and tobacco smoke. We have a lot of children who are suffering from being secondary smokers from their parent or caretakers. The role of cystic fibrosis, primary serial dyskinesia. We also have we have also diagnosed few patients from this, and the immune deficiency challenges as part of this part of the world. We have things which are variable elsewhere. So we have been seeing patients with chronic sinusitis, but most of these patients will pick them during the acute exacerbation, and then if you keep a good track of them, we'll end up treating them sufficiently. So at our center, looking on the antral polyps, we see at least 2 to 3 cases in 3 months' time, and then most of them they come to us because of their failed previous medical management with nasosteroid, decongestant, and antihistamine. And of recently, the diagnostic investigation and treatment have improved almost for the past 5 years, and this is due to the fact that the number of trained staff has increased to our setup, and the availability of both rigid and flexible endoscopies have improved really the care of children population. So we are seeing the same as what our friends are seeing in presentation and the characteristic of antral polyposis, as majority being unilateral. So we are not seeing literally anything or something new, despite we are seeing late presentation of these cases. So this is a 13-year-old female who I've just scoped a few weeks ago with just in the clinic. She has been on several medical management somewhere in the periphery, but she could not have a good progress with her nasal breathing and discharge. So just looking on her nose, we could see an antral polyp on the right nose with a fully obstructed nasal apparatus, and this was just a fraction of minutes. We could diagnose it with a user-friendly nasal endoscopy in our clinic. So just to highlight on our side, renal sinusitis is a well-known matrofactorial disease, and it imposes. It has several predisposing factors, and then they are estimated to change with increasing ages. The previous presenters highlighted about the development of these paranasal sinuses with age. Management of chronic renal sinusitis in children, it really has to stand for people, for practitioners to understand the pathogenesis of the disease and proper diagnosis. So the treatment is primarily medical, and then surgery is reserved for clients who have not received any positive outcome from the medical management. And then from this part of the world, and I think elsewhere, we still need to look on other pediatric renal sinusitis concern, and in order to address it as a full package as we have been addressing in other population. Otherwise, karibuni sana Tanzania. This is just to welcome you to my country. Whenever you plan anything for post-COVID rehabilitation. And these are my references. Thank you very much.
Thank you so much, Dr. Katundu. I think, you know, there's so many examples of seeing very advanced diseases and, you know, benign tumors and a variety of things in Tanzania and elsewhere. And so I appreciate your insight on how you manage that patient. We did have one specific question, and we have a little time before moving on to Dr. Goldberg. If one of the participants had asked if about ciliary dyskinesia, and if that had been considered in this patient, although, you know, I think with the mass that presented, there's probably other things that came up on the differential, but how do you, are you able to diagnose that, and was that something that you considered?
Yeah, so we thought of it, especially after when we had the chest radiograph. So when we have this sort of ciliary dyskinesia, or we will invite the pediatrician with us. We will just do a clinical assessment, and then we will send them to an external lab to confirm it. Yes, but it's very expensive locally to do this test. Yeah.
Yes, even here, I believe that test is quite elaborate to do. So, well, thank you very much. I wanted to introduce a couple other people from other countries have joined in the interim. We have participants from South Africa and Kenya, in addition to the countries I had mentioned before. One thing I wanted to highlight, as you know, and perhaps many of you are already on these kind of forums, there are a couple of WhatsApp forums from otolaryngologists all over the world. There's one specific to otology. So it's been a very nice way for people to share cases, photos, get advice from ENTs all over the world, many of whom have similar resources and you know, advice from all parts of the world. So if I would encourage you know, everybody to start thinking about getting on group WhatsApps that can be shared quite globally. I think it's quite a nice and easy way to gain advice in complicated and complex patient scenarios, much like the one Dr. Denis just presented. Okay, so we'll move on to our third and final speaker. One of my wonderful colleagues here at UC San Francisco in California, Dr. Andrew Goldberg. He's the director of the Rhinology and Sinus Surgery Department here at UCSF, and he knows Dr. Denis. He has visited KCMC in the past, and I know has intention to go back to Tanzania in the future. So without further ado, I present Dr. Andrew Goldberg. He'll be presenting on the topic of subperiosteal orbital abscesses and the role of external ethmoidectomy in their treatment.
Great, thank you so much, Lia. It's really wonderful to be a part of this conference. I've not been a part of Mending Kids before, And it's really fantastic to see the extent of impact that conferences like this can have. I'll share my screen. Good, hopefully you can all see that. So I'd like to talk today about orbital subperiosteal abscess and talk not so much about the endoscopic approach, which I'll mention, but talk about the role of external ethmoidectomy. This talk is put together with some input from Dr. Bob Kirsten, who's one of our colleagues here at UCSF in oculoplastic surgery. So I have some disclosures. I'm a medical device developer, and I have some patents, none of which I'll talk about here. My other disclosure is, yes, I've been to KCMC in Moshi and met Dr. Denis Katundu there. He's not in theater this day, but it was really wonderful to have that experience and to help in any way I could. And here's Dr. Des Chusi, who is someone I met here in San Francisco and who invited me to come to Tanzania. So here are patients who've presented with orbital symptoms. And what's interesting about all these patients is none of them have a subperiosteal orbital abscess. And in fact, none of them actually even have sinusitis. And so this disease can be mimicked by many other things. This first patient has a preseptal cellulitis with a lid abscess. And you can kind of get the sense that this is coming through here. And there's no other sinus or orbital disease in this patient. The second is a young boy with idiopathic orbital inflammation, or what was called orbital pseudotumor. And you can see, in fact, as somebody started to mark him up for surgery, but of course, this doesn't need surgery, this needs steroids. And here's another patient with that same problem who maybe is a little bit more of a mimicker of orbital subperiosteal abscess. This next patient has orbital cellulitis with a cavernous sinus thrombosis. And this was hematogenious. So there's no evidence of sinusitis in this patient, but there is evidence of orbital cellulitis along with that cavernous sinus thrombosis. And this last patient has acute dacryocystitis. So she had a history of a motor vehicle accident 4 months prior and had an unrecognized nasolacrimal duct injury and was sent to me after having recurrent bouts of acute dacryocystitis. And of course, what she needed was a dacryocystorynostomy, which I did perform endoscopically with good success. So what I'm going to talk about today is the presentation, diagnosis, management, and surgical drainage of subperiosteal orbital abscess. So when we talk about orbital complications of acute sinusitis in children, we often hear we'll talk about the Chandler classification, which is really a progression from preseptal cellulitis to orbital cellulitis, subperiosteal abscess, which you can see here in this middle picture, orbital abscess, and finally cavernous sinus thrombosis. And as all of you know, this can lead to meningitis, brain abscess, and death. And it's a very serious problem and one that it's good to address as early as possible. So the clinical presentation, and yes, this child does have subperiosteal orbital abscess, usually is with eyelid swelling. This patient has some proptosis. They often have pain with moving the eye with extraocular motion, decreased visual acuity, and also some restriction of extraocular motion. Now, it's not always ophthalmoplegia, it's not always complete, but there can be some restriction and diplopia in these patients. I want for a moment to highlight the orbital septum. So this is a sagittal view. You can see the orbit here. You can see the roof of the orbit and the here with the supraorbital bar. The orbital septum is an extension of the periorbita that comes out of the orbit and extends this way down through the eyelid and attaches to the tarsus. And infections in front of this barrier tend to be not as serious and are eyelid infections. And infections behind this barrier are actually in the orbit and what we call post-septal infection. Patients with post-septal infection in the pediatric population tend to be a little bit older. They will typically have fever. They virtually always have sinusitis or signs of sinusitis. And often they'll have some orbital symptoms and signs like diplopia, ophthalmoplegia, and proptosis. So we differentiate preseptal from post-septal infection. How do we evaluate these patients? Well, we take a history, almost always with an upper respiratory infection and sinusitis in an acute setting. We ask about trauma, neurological symptoms, and other things. I want to highlight the physical examination with endoscopy. And yes, this patient does have a subperiosteal abscess on the right side. And I should mention that all of the pathology will be in the right eye. So every time you look at a picture, except if I say otherwise, it will be on the right side to make it easy to orient. You want to measure visual acuity, have your ophthalmology consult help with this measurement, as well as with a fundoscopic examination. Look for extraocular motion dysfunction and pain. You want to have the eye pressure measured to see if the patient has an elevated pressure, and measure proptosis. You can see here that there's a little bit of scleral show, and there's more scleral show on this side, a little bit of ptosis, and this patient does indeed have proptosis. And you can also see displacement of the globe inferolaterally in this particular patient. So the bacteriology of this, and again, this is the right side, orbital septum, middle turbinate, this is the lateral nasal wall, is almost always strep. So strep is by far the greatest offender in these acute problems. You can see here a suction tube that's taking a sample directly from the middle meatus and sent for culture. You can have others, you can have anaerobes and staph, and often these are polymicrobial infections as well. As far as radiography, it's very important in differentiating. As you could see, the clinical examination of many of these patients is very similar to other pathologies, and you really have to identify what the patient has. And so CT with contrast of the sinuses and brain is very important. When you have one complication of sinusitis, you often will have more than one complication of sinusitis. And so you need to be aware of other potential complications that might be occurring. If there is suspicion of intracranial complications, especially cavernous sinus thrombosis, we will typically get an MRI scan. It's not absolutely needed, but it can definitely help with the evaluation of those issues. And here are some CT scan findings. The vast majority of subperiosteal orbital abscess are on the medial side. 75, 80%, the vast majority will be right here. So let me just take a moment and say this is the normal side on the left. You can see the globe. You can see the extraocular muscles here, the inferior rectus muscle, the inferior oblique muscle. You can see fat, which is darker, obviously on a CT scan, bone, which is white. The periorbit is not really visible. It's a very, very tightly bound layer right against the bone. And so now let's look at the diseased side, where you see this subperiosteal abscess with gas in it, which is very important. This is an emergency. This needs to go to the operating room and be drained because of the gas. It's putting pressure on the eye. You can tell the globe is being displaced inferolaterally in this patient. On this axial scan, you have this characteristic fusiform bulge. This is the medial rectus muscle that's being displaced. You can also see that the globe is becoming oblong in shape. And this is because on the normal side, the optic nerve is a little bit loose and the globe is round. But as proptosis happens, the globe is tethered posteriorly by the optic nerve and starts to become cone-shaped or look like a guitar pick. In this case, we have a superior subperiosteal abscess, and you can see it here, displacing the globe inferiorly. You can tell that this patient has proptosis. Again, we get this sort of a cone shape because of stretch from the optic nerve in this patient. We have characteristic frontal sinusitis, which is a little more common in patients who have the superior subperiosteal abscess. And so, so this is a patient who may very well need surgical drainage. Intracranial complications. And so this is a patient with a superior subperiosteal abscess, superior medial. There's trauma in this patient. There is intracranial involvement with an abscess in this patient. This is a contrast scan, and you can see some of the outline of this abscess. And I must tell you that it is absolutely critical to look at the axial scans, to look at the soft tissue windows, and to have contrast. I've personally looked at some coronal scans of patients with the brain abscess in the frontal lobe and have not been able to see it because I was looking at a bone window without contrast in a coronal view. So the axial view is very, very helpful. This happens to be that same patient 3 weeks later. And so this is now a cold abscess and needs to be addressed by neurosurgery. And here's an MRI scan. This axial view demonstrates cavernous sinus involvement in this patient. And you can see here on the coronal view that the vein, the spheroophthalmic vein, is involved actually bilaterally in this patient, and it's enlarged, related to some restriction of flow from the cavernous sinus thrombosis. So let's talk about management and indications for surgery. Well, these patients get admitted, they get IV antibiotics, they get serial examinations, because really the examination of the patient and how it evolves over time is critical in deciding how these patients will be managed. Immediate intervention, surgical intervention, might be needed for patients with poor visual acuity, for ophthalmoplegia. Now, not just restriction, a little bit of restriction, but really a frozen globe. Intracranial complications in order to remove the nidus of the infection, and anaerobic infection and gas, as we saw previously in that other CT scan. Those patients need to go to the OR right away. Other indications, we often talk about the size of the abscess as being important, and we'll talk about this soon. Size greater than 1 centimeter seems to be one cutoff. An elevated intraocular pressure of greater than 20, and proptosis of greater than 5. And these are other indications for surgical intervention immediately. However, the vast majority of patients will actually be able to get antibiotics, and the majority of patients will not need surgery. So we typically will give them 48 hours of IV antibiotics, and we'll look for lack of improvement. If they have not improved in 48 hours, it's a surgical disease. If they get progression of their disease on antibiotics, you don't have to wait the whole 48 hours. If you have significant progression, then you need to go to the OR. Worsening ocular examination in terms of visual acuity, the extraocular motion, proptosis, things like that. If they're worsening, that's an indication to go to the OR. And persistent fever. This group at the University of Pittsburgh, where I did my residency actually many years ago, looked at 108 patients, and I believe this is the largest group of orbital subperiosteal abscess in the pediatric population that was reviewed this extensively. 50% of the medial abscesses went to surgery, and 75% of the non-medial, and almost all of these were superior or superior medial abscesses. You can get inferior abscesses as well, and you can get some lateral, but for the medial abscesses, they have a better chance of resolving with antibiotics, and the superior abscesses don't resolve as frequently on IV antibiotics. If you look at the ones who went to surgery by size, the ones that were greater than 1/2 a cc or 1/2 a milliliter tended to go to surgery, and only 31% of the smaller abscesses went to surgery. However, what I will tell you is that a proportion of the patients with the larger abscesses didn't go to surgery, and a proportion of the abscesses who were small did have to go to surgery. And so really proceeding with antibiotics and following these patients is really critical for virtually all of these. And in this particular series, they used an exclusively transnasal approach in 54%, an external approach exclusively in 6.8%, and a combined transnasal and external percent in 39%. So a significant number of these patients require an external approach. And some of these are the superior abscesses that we'll talk about, but some of these, even the medial abscesses, might actually need an external approach. And so I won't really be talking about this, but you can see this patient. This is, again, the right side, septum, middle turbinate, lateral nasal wall, that there's a bulge here. In the other patient, you saw more purulence, but it can be very difficult to operate on these patients and get into this small space and drain that abscess. A few things about that. Number one is that I do tell patients that if I can't adequately drain it, I might go external. It's pretty unusual for me not to know in advance, but I tell them that. I also tell them that we may need to go back later, because some of these patients, because of the inflammation and because of the edema that they have, they will scar and they'll get lateralization of that middle turbinate. And so as I re-examine these patients, I look for that, and some will have to go back to the operating room later for repair of that lateralized middle turbinate or obstruction of the sinuses. I'd like to focus a bit on the external or Lynch approach. This is an external approach that stays outside of the periorbita. The incision is not really close to the medial canthus. It's halfway between the nasal dorsum and the medial canthus. This gives a better cosmetic result. The closer in you are, the more the chance of webbing and visible scar afterwards. So you really want to keep that on the lateral nasal wall, halfway between. Here's a patient who had this done. This happens to be with a W closure, and so you can use a broken line closure. Personally, I tend to use put a notch in the center of this to help prevent any scarring and contracture. But there are a number of different ways you can make this incision, but the location is actually quite important. Looking at the pertinent orbital anatomy, this is the right side. Here we have the bony orbit. We have the lacrimal fossa right here, and you can see it descending in the orbit through the maxilla, lacrimal bone. This is a very important landmark. This is the frontoethmoid suture line. The anterior and the posterior ethmoid arteries both come through this suture line. You don't want to be up here, you're intracranial. You want to be in this area. The good news is that this is actually the area where you have the majority of these abscesses form. Right here over the lamina papyrica, which is accessible intranasally through an ethmoidectomy, or is accessible externally through this approach. Here's a lateral view, and what the important numbers to remember are that the anterior ethmoid artery is 24 millimeters from the anterior lacrimal crest right here. And then it's another 12 and another 6 until you get to the optic nerve. So 24 to the anterior ethmoid, 12 to the posterior ethmoid, 6 to the optic nerve. And for the most part, you won't be up here. You'll be in this area here. You should identify the frontoethmoid suture line, only to know that you're staying below it to drain this abscess. In terms of this anatomy, you see here the periorbita, very closely applied to the bone, and the orbital contents, including muscles and fat. And obviously the ethmoid is here. In this picture, you see the nasolacrimal apparatus. And by cutting away the skin, you can see its position with regard to the nasal cavity. When we make our incision, we're making our incision way out here. So we don't ever violate the periorbita, and we don't ever see the nasolacrimal apparatus itself. As you can see in this picture, we make our incision, we go right down to the periosteum here, and we just travel along the bone. Your job is to dissect the periorbita, the periosteum from the bone, and pretty much that's it. You extract all the orbital contents medially, including the lacrimal apparatus, including the orbital contents. Here you can see that frontoethmoid suture line. And what I do in these patients, well, I can tell you also that as you dissect this, you will get a gush of fluid. So it is, these abscesses are typically not subtle. As you dissect this periorbita, you will get into the abscess, and the abscess will immediately drain into your field. You do a culture, suction it out, obviously irrigate, make sure that you have the entire abscess completed, that there are no loculations, which there typically are not, and your abscess is drained. This is an example where you can actually put an endoscope in to this open procedure. You can see the lamina right here. This is the anterior ethmoid artery coming out. You can see the frontoethmoid suture line beautifully. This is the orbital periosteum. We leave this alone. There's no need to violate the orbital periosteum. And using the suction freer, you can easily dissect this out and drain that abscess. In terms of the scar is usually quite nice. Here's a patient who had an external ethmoidectomy. Here's another patient, and the scar is really quite good. Now, interestingly, this patient had a bilateral external ethmoidectomy and had webbing on this one side. This was done like 25 years ago in Germany, where she's from. And so you can get webbing of this scar, particularly if you place it too close to the medial canthus. And this actually can be easily revised if you ever needed to. It's not a common occurrence, but obviously it does happen. And this patient with slight hypertrophy of that scar and actually was quite happy with his appearance. So I didn't want to stop before I talked about an upper eyelid incision for the orbital roof. So here's a patient with the superior subperiosteal abscess, this is the patient we saw before, you can see this lid crease. And so you can do this superior drainage, not necessarily through an external ethmoidectomy approach, but this is actually done by an ophthalmologist through an upper lid approach. And you can do this very easily in the operating room. And here is that approach. This shows the full upper lid bleph incision, but really you just need to do this medial component. And you want to travel through the skin and the orbicularis muscle, and then stop at the orbital septum. So you stop at that periosteum, and then you just elevate and follow the orbital septum up, and I'll show that again in a moment. Here's that patient with this, and he actually had a separate frontal sinus trephine with a drain put in at the same time. And so again, as we go through the skin and the orbicularis, you want to travel up and expose this orbital septum and periosteum. And at this point, you can cut down on the periosteum, and then the abscess will be right in this location outside the periosteum, right next to the bone. So again, the transnasal approach is used in most of these, but an external approach is used in some, and a combined approach is really used in a significant number of these patients. And so it's good to have those in your toolkit so that you can approach and take the patient's problem away as best as possible. So in conclusion, complications from sinus infection can be serious and deadly. Early recognition and treatment can actually save lives. This is an important function that we perform. Most subperiosteal orbital abscess can be treated medically and reevaluated over the course of 48 hours. And some of these patients don't need surgery. In fact, in some studies, up to 90%, but certainly half or 60% don't really need surgery. Immediate intervention is typically indicated for a reduction in visual acuity, ophthalmoplegia, that's a frozen eye, intracranial complications, and anaerobic infection with gas, as we saw in that other patient. Failure to respond or progression of disease over the course of that 48 hours requires surgical intervention. And endoscopic and open approaches can be used to drain a subperiosteal orbital abscess. Thank you very much.
Thank you, Dr. Goldberg. Well, now we have a little bit of time to open it up to questions. If any of the participants have any questions, you can, as I mentioned before, put them into the Q&A, or if you don't see the Q&A, the chat is fine, and we'll monitor them. I wanted to, so there's one open question, but one thing I wanted to just piggyback off of Dr. Goldberg's discussion is, in the pediatric population, and I think you mentioned this, I think even, less frequently, the need to operate, I think with careful observation is there. Kids tend to drain a little bit easier with antibiotics. And so, but as Dr. Goldberg stressed, I think making sure to be doing the serial exams and paying attention for any negative sequelae or changes is really important in making a decision to wait or to operate on these kids with subperiosteal abscess. Okay, we have one question from Dr. Clements from Zimbabwe regarding endoscopic septoplasty and does age matter? So we didn't talk too much about septoplasty in children, but I think this is a good topic that does come up when we talk about rhinology in kids and nasal surgery. He's asking about issues with the growth plates on the septum. How important are they, and what is the risk of facial hypoplasia following endoscopic septoplasty in children? I think you could even extend this question to septoplasty in general, as well as having it done endoscopically. And I have some thoughts on this. I don't know if any of my other colleagues want to jump in first. Sorry, my light just went out.
Sure, I can make some comments on that. So the good news is that septums typically deviate more as you grow. And so the septal deviation is a problem mostly that happens with an increase in the height of the septum when there isn't a sufficient space in the vault. And so we typically see in the puberty in teenagers when they start to get more of a septal deviation. Septal deviation in kids is not typically symptomatic, but there are some where it is, and you might need to do a septoplasty. There have been some very good studies that looked at this. In fact, there's actually a recent review from 2020 that reviewed the literature on endoscopic septoplasty in children, and it found in general that there is not much discernible change in the growth of the nose. Of course, these studies obviously follow kids over time and then compare them to norms. And so they're not ideal in terms of our understanding of changes in the growth of the nose, but they do offer at least the information that we have available. I think that it's prudent to be conservative in septoplasty in children regardless. And so if you do need to perform a septoplasty, I would be conservative. But in general, there isn't really a discernible change in the growth of the nose over time.
Yeah, I would agree with Dr. Goldberg's statements, and that is something that has been coming out more recently in the literature about the risk of hypoplasia, perhaps being demystified. I think too, oftentimes I've seen the severe deviations that do need to be addressed are often more anterior in the cartilaginous septum, and something to keep in mind when addressing that is, even without growth plate issues, the facial growth is growing and changing in children. So if something is performed on the anterior septum over time, I've seen sort of cosmetic deformity from over aggressive surgery in that area, and anterior septums deviating with time. Just I think as a result of children continuing to grow, that's a risk in adults as well. You also just have less room to work in kids to do a septoplasty, and less cartilage and bone to work with. So being really careful and as Dr. Goldberg mentioned, conservative, I think is a good approach to those. Okay, we have a question from Dr. Chusi. Thank you, Dr. Goldberg, for the nice talk. I saw 2 patients last year with late presentation resulted in chemosis and frozen balls or globes, and of course, total blindness. Can you share your experience with ophthalmology colleagues in making sure that the abscesses are taken care of, since many that I know prefer medical treatment in their initial encounter? That's a good question.
Sure. First of all, great to hear from you, Des. He and I met many years ago in San Francisco when he was on an educational tour here, and I was able to come to KCMC where he practices. So we're fortunate to have a very close relationship with our ophthalmologists here, particularly our oculoplastic surgeons. And when they see a subperiosteal orbital abscess, if they see it independently, they'll call us pretty much right away, because they know that we have expertise in helping to drain these and can address other issues with sinuses, et cetera. But it really is a partnership, and it's helpful to have some conferences together, to have these relationships form before you actually have an acute patient come in with a problem like this. So we often will take the patients to the operating room together. Particularly the ophthalmologists like to perform the upper lid incision and to go forward with the drainage of a superior abscess. We will typically do the drainage of the subperiosteal abscess endoscopically or open, potentially in combination with them. So I think that really the take home is, as much as possible, form those relationships first, have some conferences, have some meetings, and when the acute patients come in, then you'll already be a familiar face. It can be hard to do because it's true that sometimes literature from different specialties will address problems in a different way.
Yeah, something that has become, I think, more commonplace here at our institution at UCSF and other places I've trained is multidisciplinary conferences. So as opposed to just having grand rounds or lecture series within your own specialty, I think a great way to relationship build with other specialties is by having the multidisciplinary conferences. It's an opportunity to share different perspectives, and I think overcome some of perhaps the political challenges that can arise with different specialties and competing ideas and priorities to have those forums. So I would encourage that. I don't have any other questions. I was interested, Chowie or Christina, and if we could show the panelists and see if we could do a quick Q&A with a raise of hands. I was curious to see how many of our participants have a CT scanner in their facilities. I think there was a lot of focus on CTs, and hopefully some good information gleaned from these talks. I know that in Mwanza, and this has changed over the years, but oftentimes if it isn't communicated with the radiologist or the techs performing the scans, we're not getting the proper imaging to really complete a full assessment. And so I think I had some tips on that, but I wanted to see how many of our participants actually have access to a CT scanner. Is that something we could do?
Charlie, are you able to do that?
I think we can look at the the attendee board to see the number of hands rising right now. There's one.
Yeah,
participants,
there's an option to raise.
Yeah, you'll see the number of hands up.
Okay, good. Yeah, we're seeing, let me see here. So far, a small number of people, and it might be that some of this is just Zoom, but I know that we, all over it's very different, and not everybody has access to CTs. So I think for those of you that do, for sinus imaging, I think it's important to have very thin cuts, or a small amount of millimeters, even up to 1 millimeter cuts on the scan. Sometimes we're receiving the scans on film, and so being able to look at those in really fine cuts is how you're able to really gain information about the the skull base, the arteries, anterior ethmoid, carotids, posterior ethmoids, etc. Without that detail, you can miss big defects. And so sometimes that's really important to communicate. And then also knowing that asking your text to print out the coronal, sagittals, and axial views, depending on what you need and what you are concerned about. I think ideally having all three is quite critical if you're doing endoscopic sinus surgery, especially if you're going to be working near the skull base. If you're staying within the nasal cavity, perhaps not as important, but I think it's an important thing to keep in mind in terms of safety. Is Dr. Willner stressed this in his talk, is knowing the landscape is quite important. And then
I wanted to add that you're not always going to be able to get that scan, and if it's not a 1 millimeter or 2 millimeter cut scan, it doesn't mean that you can't do the surgery. I mean, if you need to drain a subperiosteal abscess, you need to drain a subperiosteal abscess. It means that you have to recognize the limitations of what you have. If you stay inframedially, you will go into the bulla, and you can, once you're comfortable that you're in the bulla ethmoidalis, then you can go laterally and superiorly from there. Same thing with the posterior ethmoid, and same thing with the sphenoid sinus. Staying inframedially will keep you safer, but most importantly is to understand what the limitations of the scan are, and it may limit everything that you can do. That doesn't mean that you should do nothing. It means you should keep that in mind.
Yes, thanks, Dr. Willner. That's great. A couple more questions here from participant L. Rush. Thank you for the talk. In regards to subperiosteal abscess, apart from antibiotics, is there a role for using steroids?
That's a very good question. So that issue has been studied, and there doesn't seem to be any specific advantage to using steroids. One of the questions that you have to ask is there a disadvantage to using steroids? So it seems that using steroids or not using steroids wasn't particularly important, but I will say that we tend to use steroids, and especially in patients who have visual compromise. But you must do that in conjunction with antibiotics. And so the most important thing is to get those antibiotics on board as quickly as possible. I also saw some questions about what types of antibiotics might be appropriate. And so I'll tell you that our number one is ampicillin sulbactam or Unison. Something that will be very effective for strep is very important. You can also, if you can get it, ceftriaxone, which is a cephalosporin medication. Clindamycin can be effective. And for patients in whom you suspect MRSA, methicillin-resistant staph, we would typically use vancomycin. So the number one bug to cover is strep, especially in these rapidly moving infections. And we definitely like to use something with a penicillin and preferably a beta-lactamase inhibitor as well.
Great. We have a question about, in the pediatric population, do you routinely do sinus rinses prior and post-surgery, plus or minus budesonide, especially in polyposis patients?
I routinely do use rinses, either saline or even it's called alkalol, A-L-K-A-L-O-L. It's a bunch of astringents. I don't know how available it is across Africa. Certainly saline is good, and budesonide in cases of polyposis has been shown to be beneficial, and it's topically applied, so and should be coming out. So.
And I think we have time for one more question. This is from Dr. Clements. How challenging is bleeding in the endoscopic approach to subperiosteal abscess drainage? And in an LMIC setting or low and middle income setting, would you recommend this versus sticking to an open approach?
Well, I'll say that certainly these patients are typically inflamed and bleeding can be an issue, but I will tell you that generally you can control it. And I think that's something that Dr. Willner said is incredibly important, and that is you have to leave the pledgets in place. So what I typically do when I'm doing any sinus surgery, and particularly one with an acute surgery, is I will do my injections, I'll place my pledgets, and then I will leave. I'll go over to the board and I will look at the CT scan and I will review the CT scan. I usually have a resident with me. So we'll go over the different functions of the different factors on the CT. And hopefully, if I'm lucky, it'll take between 5 and 10 minutes so that the medicine can work. And then I come back and my decongestant has been effective. And I will also say just two other things, and these also are things that highlight something that Dr. Willner talked about earlier. I look at surgery as a systematic movement from landmark to landmark. And so before you proceed in a surgery, you have to know where you are. Whether you're using the middle turbinate, the uncinate process, the maxillary sinus, you remove the bulla and see the medial orbital wall. So in each of these steps, you're establishing where you are with good certainty, using an image guidance to confirm if it's available. But really, the anatomic landmarks are what you need in order to move from one step to the next step. And if those landmarks are obscured with bleeding and edema, it can be very troublesome and dangerous even to move forward. And so if there's bleeding, stop, put in some pledgets, take a break, let the pledgets work with your epinephrine, and then come back. In an elective case, if you are encountering bleeding or polyps that are causing you trouble and you're having trouble with your landmarks, stop. I've done it. I've never had a patient say, oh, that doesn't matter. You couldn't see where you were. Why didn't you just keep going? Nobody says that. Everybody is thankful to you that you have their best interest in mind and you've stopped the surgery when it was becoming difficult to do.
Thank you so much to all of our panelists and our attendees. As I've mentioned, I'm just so grateful to be a part of this forum where we get to bring so many people from around the world together to discuss these topics. Please, to all of our attendees, if you could please fill out the survey from Mending Kids. If you have any suggestions on future topics, we would like to periodically continue to do these virtual forums. And I will also see about starting a WhatsApp chain with, with all the participants, those of you who are interested at least, so that we can start having some collaborative discussion in the interim, if that is useful. So we may reach out with an email about that in the future.
Yes, and on behalf of Mending Kids, I'd like to thank all of our panelists for presenting today and providing this exchange of knowledge. And as an organization, we're always looking for ways to use technology to bring people together, to be able to advance and elevate the standards of care. And so we're always on the lookout, whether it's through smart glass technology or 3D printing or other ways to just sort of advance practice. And so, as Dr. Jacobson said, it's so important to us that you fill out this survey. I know it's a little bit tedious to get one more email from us, but it's critical for us and the support that we receive as an organization to be able to provide these free of charge, and to be able to work with our doctors who all donate their time to be here. This is out of the love of teaching and the work that they do. So I want to thank Dr. Goldberg for your fascinating presentation, and Dr. Katundu from Tanzania for being here, and of course, Dr. Willner and Dr. Jacobson for being the pillars of our ENT symposia, and Christina Farut, our Director of Mission Services, and Jeffrey Scher for putting this together. So thank you again. This conversation will be available on YouTube, and we will share the link with you when we publish it. Thank you again.
Thank you.